Hello all. Thank you to Sages for having me. My name is Julia Hamilton. I'm a third-year medical student at Washington University, and I'm here to talk to you about how polypharmacy predicts postoperative complications in older adults undergoing transversus abdominis release. I have no relevant disclosures. So in this talk, we're going to first talk about transversus abdominis release and how it affects the elderly. I'm then going to introduce polypharmacy, an important factor in geriatric care. And finally, I'm going to introduce the study, talk about its results, and some implications. Ventral incisional hernias are extremely common and occurring about after half of all laparotomies. This is on top of the 5% of the US population that will develop either an epigastric or umbilical hernia. At the same time, surgeons are using increasingly complex techniques for abdominal wall reconstruction. One such technique that we focus on in the current study is component separation with transversus abdominis release, or TAR. With our aging population, there will be a growing number of older adults requiring TAR. Older adults are prone to get hernias due to ineffective tissue repair and weak interior abdominal walls. They're also at greater risk for poor outcomes, including intestinal obstruction, strangulation, and the need for urgent repair. With these potential risks, it's important that we ask ourselves which older adults would benefit from TAR, and from which should we employ a watchful waiting approach. Existing literature, as we heard earlier, suggests that we focus on geriatric syndromes, which are factors that are associated with both aging and poor health outcomes. While this relationship has been demonstrated in various medical and surgical specialties, little research has been done in regards to ventral hernia repairs and TAR in particular. For the present study, our group focused on polypharmacy. Polypharmacy is the use of multiple medications at the same time. There's no consensus on definition, but it's often operationalized using a strict numerical threshold, like 5 or more medications. Unsurprisingly, polypharmacy disproportionately affects older adults, likely due to multimorbidity in this population. It's been linked to a number of adverse outcomes, including drug-drug interactions, medication non-adherence, falls, delirium, hospitalizations, mortality, among others. However, our group was unable to locate any existing studies showing how polypharmacy affects outcomes following TAR. And this is what we sought to explore in the current study. This is a retrospective cohort study of 132 patients, 60 years or older, who underwent either open or robotic bilateral TAR by 2 abdominal wall specialists. All procedures included non-absorbable synthetic mesh of all weights placed in sublay fashion, and exclusions are listed on the screen. Polypharmacy was defined as 5 or more medications, and patients were also categorized into 3 equal groups based on the number of preoperative medications that was found in patient charts. Topical medications, vitamins, minerals, and herbal supplements were excluded from the medication counts. Outcomes of interest included postoperative complications, which are listed there, discharge disposition, length of stay, and number of ICU stays in each group. ANOVA and chi-square were used for statistics. Logistic regression models were used to control for age, sex, BMI, and comorbidities. Polypharmacy, defined as taking more or 5 medications at once, was present in 89% of our patients. The third of patients with the lowest number of medications had an average of 4.7. The following group had an average of 10.3 medications, followed by 17.9 medications in the highest group. Overall, the average was a staggering 11.2 medications per person taken every day. Shown here in the red box are the baseline characteristics of the 3 groups, and as you can see, the only factor that differed between the 3 groups was Charlson Comorbidity Index, a measure of comorbidity, and unsurprisingly, those with more comorbidities had a higher number of medications. Moving on to results, the medication-heavy group, which is group 3 in this graph, had significantly more complications per patient as compared to the other groups. This is a significant finding. Taking a closer look at specific post-op complications, delirium, shown here in red, and cardiac events in gray, are significantly more common in the high medication group. And this effect persisted even after we controlled for age, sex, BMI, and comorbidities. So since polypharmacy affects postoperative outcomes, it's not surprising that it may also affect discharge disposition. In this graph here, discharge to home is seen in red, and discharge to a skilled nursing facility is in gray. As you can see, the only patients that required discharge to a skilled nursing facility were in the medication-heavy group. This was a significant finding, and it remained so even after controlling for age, sex, BMI, and comorbidities. There are also a few trends that did not reach significance, but point to a possible detrimental effect of polypharmacy. First, shown here in red, length of stay was longer in the medication-heavy group as compared to the other two. And then next, in gray, the number of patients that required an ICU stay was, again, higher in the medication-heavy group as compared to the others. This study first showed us that polypharmacy is extremely common. It's present in 89% of the patients of the older adults undergoing TAR in this study, and with an average of, with them taking an average of 11 medications every day. In addition, polypharmacy may serve as one factor that could predict negative outcomes following TAR, such as postoperative complications, discharge to skilled nursing facility, length of stay, and ICU stays. As such, polypharmacy may be used to inform preoperative decision-making and may present an opportunity to intervene prior to surgery. Along with other geriatric syndromes, polypharmacy will likely be an important factor as we address the increasing need for TAR in our aging population. Thank you.